Welcome to the first in our series of webinars addressing tobacco use, policy, treatment among people living with mental and behavioral health challenges. I remember when I was working at Eastern State Hospital as a psychiatric nurse, one of the prevailing issues that we faced was the normative use of tobacco within the facility. And it was a challenge knowing that as a nurse, somebody who is supposed to promote health, I was using tobacco products as a reward for behaviors. This just illustrates how prevalent tobacco use has been within mental and behavioral health settings, which has caused some to call it the hidden epidemic. So we're going to talk a little bit about addressing this hidden epidemic within mental and behavioral health settings. So I'm Zim Okoli, and I am the Director of the Behavioral Health and Wellness Environments for Living and Learning at the UK College of Nursing. And I really appreciate your being able to attend for this presentation today. The main goals of the presentation are to describe some of the factors associated with tobacco use among persons living with mental and behavioral health challenges, and to discuss best practices and interventions to address tobacco treatment within these settings. So why do we want to address tobacco use within these populations? And what are their particular challenges? When we look at research studies in the space of over nearly 20 years, this graph shows that there was a decrease in the tobacco use prevalence among adults 18 years or older. But when we look at those with serious psychological distress or those living with mental illnesses, we didn't see the same decrease in the tobacco use prevalence. Even today, a gap still exists where we have 50 years of tobacco control in this country. We know what works. We know how to address tobacco use and prevalence. However, the question is, for people living with mental illnesses, why do they not benefit from the science that we know works? When we look at some more recent data, we also see that this gap remains for those with serious mental illness as well. When we look at clinical groups, so these are groups of individuals who may be hospitalized, we recognize that the black bars to the left, which demonstrate people with mental illnesses, severe mental illnesses, versus the white bars to the right, which illustrate people with substance use disorders, we still see, compared to the grayed out bar to the rightmost, individuals living with substance use disorders and mental health challenges are still using tobacco at 2 to 3 times the rate of the general population, which shows us that this is a serious illness and this is a serious issue that needs to be addressed. Individuals living with mental and behavioral health challenges who use tobacco die on average 10 to 25 years earlier than those who don't. They have greater psychological symptoms of depression and anxiety, have more substance use problems. They certainly have more of the cardiovascular, cardiopulmonary risks that we know are associated with tobacco use. They're more likely to die by suicide, and they have sexual problems. In contrast, those who do not use tobacco have better health, they live longer, they need less medication in order to resolve the symptoms that they face. They have less depression and they save more money. In other words, tobacco use in these populations, in addition to the ill health that it causes, it's a serious impairment to their ability to achieve recovery. When we look at death certificates related to people living with mental and behavioral health challenges, we don't see people dying from schizophrenia or bipolar disorder or even depression. But what we do tend to see are people dying from tobacco-related illnesses. These are illnesses based on either their primary tobacco use or the exposure to secondhand smoke from tobacco. In other words, some have argued that tobacco use is the #1 killer in these populations. Hence, it really needs to be addressed. But we'd like to know, what are the reasons for this increased use of tobacco among people living with mental and behavioral health challenges? When we look at research studies, they give us about 3 different main clusters of issues in these populations that relate to tobacco use. One is the genetic aspect, where individuals living with mental and behavioral health challenges, they may have polymorphisms, changes in their genes that predispose them to either initiating tobacco or after they initiate it to become addicted. So we found these relationships among people with major depressive disorder, with those with post-traumatic stress disorder, and with schizophrenia. So again, there seems to be a genetic vulnerability that links tobacco use for people living with mental illnesses. Another aspect is what we call biobehavioral, in the fact that tobacco products and some of their constituents have biobehavioral effects. As an example, as I'm speaking, you're probably, who knows, you're listening to this video, but at the same time, there may be people in the background speaking to you, or there may be, I don't know, in the world of Zoom, cats walking across, the screen, children in the background, and so on. But as you're listening to this video, you're able to focus on me. And that's called neurogating. You're able to block out other sensory input to focus. Individuals with schizophrenia have a challenge in their neural gating or their sensorimotor gating. However, nicotine actually enhances their ability to gate. So nicotine might be functional, but remember, tobacco is constituted with over 7,000 chemicals which kill. Another example is that in smoking, in the cigarette smoke, there's something that reduces the levels of the brain levels of the MAOA inhibitors, which tends to cause people to have less depressive symptoms. We know it's not the nicotine, but it might be something in the cigarette smoke. And also, nicotine itself is an anxiolytic. It can help relax people. And so you do hear many tobacco users say, well, I feel stressed, so I'm smoking. So there's certainly a biobehavioral link between people using tobacco, probably to take care of some of the dysphoric states they experience in mental illness. And finally, tobacco has been used for many years as a token economy. There's this strong psychosocial aspect that tobacco use has been normative in mental and behavioral health settings. It's even been used in the past to encourage patients who live with mental and behavioral health challenges in order to socialize. Again, we need to address these issues in order to enhance tobacco treatment uptake among these populations. Well, why are reasons for people living with mental and behavioral health challenges, why do we want to treat tobacco in them? One is that they want to quit. Preponderance of studies, even more recent studies, are showing that individuals living with mental illnesses and behavioral health challenges, they want to stop smoking. They know the harms it's causing to their body. They have challenges in stopping, but they do want to stop. Not only that, they are able to stop smoking or using tobacco products. It may require higher doses of tobacco treatment medications, and it may need longer durations of therapy or behavioral counseling, but they are able to quit once given intensive treatment that's person-centered. And finally, recent studies demonstrate that tobacco cessation improves psychiatric symptoms. Those who continue to use tobacco continue to suffer from a lot of the dysphoria caused by their psychiatric symptoms. But once they stop using tobacco, their psychiatric symptoms as a whole improve. So once again, tobacco use cessation is a proponent for them to achieve recovery. Our responsibility as behavioral health providers or those engaged in this work in tobacco control is not to neglect the fact that we know there are challenges for those with mental and behavioral health challenges in their tobacco cessation, but it's still our duty, it's our moral responsibility to be able to assist them, especially when they want to engage in tobacco treatment. We need to educate ourselves. We need to go through training if possible, so that we can become competent providers for tobacco treatment, particularly in these populations. So what can be done and what works? Well, first of all, it's important to recognize that the CDC has recommendations specifically for behavioral health settings. And first is that stopping practices that encourage tobacco use. We need to address this issue within mental and behavioral health facilities to stop practices that encourage tobacco use. We don't want to encourage smoking breaks. We don't want to encourage the giving of tobacco products to patients. In fact, we want to create environments where tobacco treatment is a norm and tobacco use is abnormal. So to do that, a second recommendation is we make our campuses, our facilities, 100% tobacco-free, not just cigarettes, combustible or non-combustible forms of tobacco, but even including the electronic nicotine delivery systems, or as people often call them, vapes. Third, we need to include tobacco treatment as part of mental health treatment and wellness in general. In other words, it's important to emphasize to those that we provide care to that tobacco treatment and tobacco cessation is part of their overall wellness. And it is an addictive behavior. It is a mental illness based on the DSM-5, and it can be treated. In order to begin this work, we wanted to get a landscape, maybe a bird's eye view of what different community mental health centers in Kentucky are doing in regards to tobacco treatment and tobacco policy. So between 2019 and 2020, we developed a needs assessment that we administered to over 159 different programs from among community mental health centers in Kentucky. And what we found was that many individuals or many programs are interested in tobacco treatment. And they are also interested in tobacco policy, tobacco-free policy. So this becomes an opportunity for us to begin addressing the needs within community mental health centers. We also asked in the same survey about their capacity to provide tobacco treatment. And we used the evidence-based 5 A's, ask, advise, assess, assist, and arrange as a template to capture their use of these brief interventions, the evidence-based ways to address tobacco in their facilities. And as we can see from this graph, there's opportunity. As a whole, the blue bars represent all the time or often that they do these practices. And the opportunity is that most of them are asking. About 50% are advising, fewer are assessing, some are providing some form of assistance in tobacco cessation, and more than half at least are providing resources or referrals to community sources. So this means that there seems to be an appetite within Kentucky community mental health centers and their programs to provide some form of tobacco treatment, but there is opportunity for improvement of these processes. We wanted to understand also, how do we provide evidence-based tobacco treatments within community mental health settings? And so this study that we conducted in 2016 was taking an evidence-based approach that we know that works, which is called the Cooper-Clayton. It was a process that was adopted. It's unique to Kentucky, adopted by the local health departments in Kentucky. And we wanted to apply it to a community mental health center or setting and see how it worked. So the Cooper-Clayton program was developed in the 80s, and it's a bona fide program. I actually studied under Dr. Clayton. So I know the program very well. And it comprises of about two main aspects of behavioral counseling and nicotine replacement therapy as the two modalities of the program. And it takes about 13 weeks. So we applied this program with the same interveners, those delivering the programs, into two sites within a similar time frame. And as this chart shows on this slide, we had a total of about 47 who enrolled in the programs. One site, the one to the left, was Participation Station, which is a community-based recovery house model program. And we also conducted the same Cooper-Clayton program in two community sites, which were not mental health based. What we found, not too shocking, is that those within participation station or the community mental health site, nobody stopped using tobacco, but almost 70% within those in the community sites that were not mental health specific sites were able to stop. This shows that the Cooper-Clayton does work. 70% of individuals were able to stop, but for some reason it didn't work within our specific population. And I asked the interveners what was different. They mentioned that the big difference was in the community mental health sites, people needed more time in their process of gaining confidence and motivation to stop using tobacco. They all enrolled in the program because they wanted to stop using tobacco. But by the time the program required people to set a quit date by week 5, individuals in the participation station were not yet ready. This tells us that in order to develop and provide tobacco treatments within the community setting, we may need to use tailored approaches. So I wanted to present some tailored approaches, and this is based on some work that I did earlier on in Canada before coming back to Kentucky, where we developed what we called a tobacco dependence clinic. These were tobacco treatment programs embedded within community mental health and addiction centers. The philosophy of the tobacco dependence clinic is that smoking cessation is a process, it's not an event. As a result, we don't require people to set a specific quit date. Rather, we motivate and enable them as they're going on in the treatment process until they feel confident to set a quit date. For some, that might be in 1 week. For others, that might be in 10 weeks. But we take a person-centered approach in this process of tobacco cessation. A second aspect of what we did is what we call titration to effect. This is a process often used in methadone replacement therapy, where you provide the nicotine replacement. In our case, for tobacco treatment, you provide nicotine replacement or the medications until you see the effect of a ceasing in the behavior that you want. For example, if a participant is a 20 cigarette a day smoker or 1 pack a day smoker, we will probably start them with a 21 milligram patch, because every cigarette represents about 1 milligram of nicotine that's absorbed. So if somebody's smoking a pack, 20 cigarettes a day, you want to give them or replace at least 21 milligrams patch. If the individual is able to reduce their tobacco use, say within a week or 2 after giving them a 21 milligram patch, they drop to, let's say, 10 cigarettes a day, we may add a gum, a lozenge, or a 7 milligram patch. In other words, we're increasing the dose of the nicotine until the behavior is extinguished. So the program as a whole involved two main treatment phases. There was an 8-week manualized closed group, and then an up to 18 weeks open group support group format afterwards. But as individuals were participating in the program, the whole duration, they were giving nicotine replacement therapy or other tobacco cessation medications as needed. So our evaluation is based on a 5-year period from 2007 to 2012, where we treated over 1,075 individuals that came to the program. Those who engaged in the program were 786. So these are individuals who came to the program and had more than at least one visit before leaving for whatever reason. Among the engagers, 623 actually completed, which means they stayed for the 8-week closed manualized group. Our results among the different groups of those who may have participated can help us understand what a program like this can offer in terms of the return on investment. So the left side, we're looking at the intent to treat group. This means if anybody came to our program for whatever reason, whether they finished or not, we had a 24% cessation rate. Now, among those who engaged in the program, who came once and at least a second time, we have a 33% cessation rate. But among those who completed the program, we're looking at a 40% cessation rate. We also wanted to understand, in terms of the process of this program, how did the intensity of treatment result in cessation? And this graph is pretty explicit. It shows that the longer duration in the program, the more likely individuals were to stop using tobacco. In other words, we may have to move away from the mindset of giving people a 12-week program or an 8-week program. In other words, if you had at least a 9 to 12-week involvement, you could expect a 35% quit rate. But the longer people stayed in the program, the more opportunity they were able to quit. So we also, moving away from community settings, wanted to understand how can we enhance inpatient behavioral health facilities in tobacco treatment. So some of my work is at Eastern State Hospital. It's a state psychiatric facility. It covers a catchment area of about 50 counties, and it has over 3,000 admissions per year. It's a 239-bed hospital. So when I started working at Eastern State Hospital in 2015, we wanted to augment the existing tobacco treatment process. And we did so by making sure we had a process where every tobacco user is identified at admission, and then the admitting healthcare provider can prescribe the appropriate nicotine replacement therapy to address nicotine withdrawal. We also have trained tobacco treatment specialist nurses who were going on the units and meeting with patients and assessing their withdrawal, as well as providing them information about tobacco cessation and tobacco education groups or tobacco counseling. What we found in a 1-year period of just collecting the data was that, actually it's more like a 15-month period. We found that, and I want you to pay attention to I think the orange bars, reddish bars. This represents practical counseling. So by the time we began our work in 2015, practical counseling rates were 68, but with the introduction of our tobacco treatment clinic, it rose to 83.8 by December 2016. We also saw similar increases in the use of FDA-approved medications and also in tobacco screening. In other words, when we use a systematic approach within an inpatient setting, then we are able to optimize the ability to provide tobacco treatment. We also conducted a needs assessment of both staff and patients and asked them questions about the use, or for staff, we asked them about their providing evidence-based tobacco treatment and patients about their receiving evidence-based tobacco treatment. And this information showed us that where patients and providers agreed that they are more likely being asked or advised to stop tobacco use, when it comes to being referred to further treatments or assisted with treatment, those parts fell short and become opportunities for us to address, especially in training of staff. So in conclusion, tobacco use remains a leading cause of morbidity and mortality for those living with mental and behavioral health challenges. Tobacco users do want to quit, and they can if they're provided evidence-based assistance. In community settings, we recognize individuals may need longer durations of treatment and possibly higher doses of medication to optimize their ability to stop smoking. And within inpatient settings and maybe other behavioral health settings, the key is we have to make sure that tobacco treatment is a norm. People should have access to tobacco treatment, and tobacco use is not a normative behavior. We need to denormalize tobacco use and make tobacco treatment a norm. This would require training of staff in evidence-based tobacco treatments. So I just want to give a shout out to our website, uky.edu/bhwell. Please check us out. We have a lot of resources. We have a Twitter handle, we have Facebook, but you can get some of the updated and latest resources on how to address tobacco treatment in mental and behavioral health populations, and some other resources that we have just in terms of general mental health and well-being. And I just want to acknowledge our wonderful, wonderful staff, faculty, research assistants, and graduate students who make the work that we're doing possible. I don't know how much better we could do what we're doing, but we have people who are very committed and passionate to this cause, and we welcome you to be a part of what we're doing. Thank you. If you have any questions, please feel free to call or to email us, and we'd be happy to work with you.